Hello, this is a recording of the Nursing Skills Lecture on Skin Integrity and Wound Care based on Chapter 31 in the Fundamentals of Nursing, the Art and Science of Patient-Centered Care. This is a diagram of the structures of the skin. The epidermis is the outermost portion, made up of stratified epithelial cells fused to form a protective waterproof layer of keratin material. It creates our skin tone. Then there's the dermis, is the framework of elastic connective tissue. It contains nerves, hair follicles, glands, and blood vessels. It's made up of collagen and elastic fibers. And finally, the subcutaneous tissue, which consists of adipose tissue. It stores fat for energy, heat insulation, and provides a protective cushioning. Contains blood and lymph vessels, nerves, and fat cells. So skin has many functions. It is the largest organ of the body. Healthy skin serves as the first line of defense against harmful agents. Table 31.1, page 958 in your text describes these functions of your skin. So you should refer to this table as well as the table 31.2 on page 959, which describes the factors affecting skin integrity. As listed here, age, younger children, and older adults have very thin and weak skin. Body type makes a difference. If you're very thin or very large, you're more susceptible to skin injury. And these other factors in health status: dehydration, excessive moisture, jaundice. Jaundice can make the skin very itchy, which leads to scratching and breaks in skin integrity. Genetic predispositions, reduced sensation, and diabetes. Diabetes causes poor healing, recurrent fungal and bacterial infections, ulcers of the lower extremities, and various therapeutic measures, immobility and bed rest, as well as casts with their rough edges can cause skin breakdown. Different medications can cause allergic rashes and itching, as well as radiation therapy can cause moist desquamation, which causes breakdown, and various lifestyle the factors make a difference too. If a person smokes, has excessive sun exposure, a sedentary lifestyle, alcohol use, stress, or lack of sleep, as well as body piercings, which can cause a break in skin integrity, increasing the risk for infections. So as a person becomes older, the skin becomes thinner, oil and sweat glands are less active, it's less elastic, and there's decreased sensation. So there's certain nursing interventions that can help. You want to avoid using tape, or if you need to use tape, use a paper tape. Check skin more frequently and check under skin folds and change the position. You want to pad bony prominences. And when you bathe the person, you want to limit the amount of soap you use. You want to be applying lotions. You want to be encouraging fluids. The table on page 960 in your text reviews some of these interventions you can employ. So a wound is a break or disruption in the normal integrity of skin and tissue. There's a normal wound healing process that the body goes through when a wound occurs. The first step is called hemostasis. It's what happens immediately following an injury when blood vessels constrict and blood clots through platelet activation and clustering. The vessels then dilate and bring plasma and blood components to the area. The second phase is the inflammatory phase. White blood cells bring leukocytes to ingest bacteria and cellular debris, and then macrophages continue ingesting the debris and start the healing process. During this time, the patient has pain, heat, and redness and swelling at the site of the wound, and there's also a systemic response: low-grade temperature, leukocytosis, and general malaise, and these are the cardinal signs of injury. The inflammatory phase usually lasts from 1 to 5 days. The next phase is the proliferation phase, also known as fibroblastic, regenerative, or connective tissue phase. During this phase, granulation tissue forms at the base. It's a highly vascular and red, fragile tissue, and it can bleed very easily, but it is what you want to see, and it represents healthy wound healing. And then with remodeling, new collagen continues to be deposited and a scar tissue is formed. Scar tissue is avascular. It cannot sweat, grow hair, or tan, and it is not as elastic. It can limit movement, particularly over joints. Scars are only about 80% as strong as the original tissue. So different types of wounds you can find listed on table 31.3 on page 961 in your text. And I want to point out particularly the ulcers. There's various types of ulcers. Pressure ulcers are formed from compromised circulation. Venous ulcers are wounds from poor venous return as a result of incompetent valves or obstruction. They're usually red and shiny and have a little more drainage than other types of ulcers. Arterial ulcers form from underlying ischemia and thrombosis. These wounds are usually dry and pale, not too much drainage. And then diabetic ulcers caused from injuries and diabetic neuropathy, poor peripheral artery disease, and diabetic foot changes. You'll see these often on the plantar surface or the ball of feet. So ulcers generally have delayed healing. This slide shows you some factors that cause delayed wound healing. One is pressure that continues this disruption to blood flow. Desiccation can lead to cell dehydration and death, and wounds should be kept moist to support epithelialization, which is cell migration to the wound bed. Maceration is overhydration. This can become caused by incontinence or prolonged exposure to moisture. And then repeated trauma can cause delayed wound healing, as well as edema that interferes with the blood supply to the wound. Necrosis is the death of tissue. This causes bacteria that produces toxins that can lead to cell destruction, as well as biofilm can be created. It's a thick grouping of microorganisms that could lead to slough, which is moist yellow stringy tissue, or eschar, which is dark leathery tissue of the wounds. When this happens, there's decreased blood flow to the area and a decreased ability for oxygen to reach the area, and wound healing is delayed. Systemic factors are also listed here: old age, obesity, chronic diseases. Malnutrition decreases wound healing because we need proteins, carbohydrates, fats, and vitamins for wound healing to occur, particularly vitamin A and C for the epithelialization and collagen synthesis, and zinc for cell proliferation. So there are many ways to classify wounds. They could be classified as intentional or unintentional. Intentional wounds result from planned invasive therapies such as surgery, whereas unintentional wounds are from accidents and trauma. They can occur in unsterile environments and have jagged edges. Bleeding is less controlled and is more likely to become infected. Wounds are also classified as either acute or chronic. Acute wounds heal within days to weeks, and they move through the healing process quickly, whereas chronic wounds, the healing process is impeded. The wound edges are usually not approximated, and often when the wound is chronic, it is remaining in the inflammatory phase of healing. Another classification of wounds is either opened or closed. Open wounds, the skin surface is open, providing a portal of entry for microorganisms and increased risk of infection. And with closed wounds, skin is intact, but soft tissue is damaged. Internal injury and hemorrhage can occur, and you'll see ecchymosis and hematosis in these situations. And another way to classify wounds is by the thickness, as you see in the diagram over here. It can be superficial, partial thickness, full thickness, or deep wounds, deep and complex. So here are a couple examples of wounds. The top two are open wounds. The first one up in the upper left-hand corner looks like it's unintentional. It's partial thickness. It looks a little necrotic. You see this the black buildup, and it's probably a chronic wound. And in the upper right-hand corner is another open wound that appears to be healing better. It's probably going to go through the healing process better. It's more of an acute wound than what appears on the other side as a chronic wound. This poor little girl has a little superficial wound. It's probably acute. It probably will heal pretty quickly. You see these frequently on children, these kind of abrasions. And then on the bottom right-hand corner, you see a closed wound. It's a fracture that hasn't broken through the skin, but you're going to see a lot of bruising and ecchymosis and swelling in this situation. Here are a few more wounds that are very disturbing. You have your chronic wound up here. It looks like it might be a venous ulcer. It looks a little red, shiny. There might be some drainage, a little bit moist. Compared to this full thickness wound on the heel. This happens very quickly if a person's on prolonged bed rest. You want to make sure you do a nursing intervention called floating the heels. You can put pillows under the calf and ankle so there's no pressure on the heels at all, and this hopefully will not be something you'll have to see. Down here, some very disturbing partial thickness wounds. You would predict, as compared to the small child on the previous slide, that looks like it was not a wound that you would worry about. These you would be concerned with abuse, and you'd want to be looking into what happened that led to these wounds. And then finally, in the bottom left-hand corner, there's an arterial ulcer. It's dry, pale, not much drainage. It's possibly a diabetic ulcer. This slide shows some wound complications. The first one is hemorrhage. Hemorrhage can be internal or external. You want to be checking dressings frequently, particularly in the first 48 hours after surgery, and then every 8 hours after that. And then if bleeding does occur, you want to add pressure, give fluid replacement, and possibly return to surgery, because hemorrhage can be occurring from a slipped suture or erosion of a blood vessel, or if it's internal, a hematoma can form. Another complication is infection. Increased risk of infection is with abdominal surgery, hospital-acquired infections. Usually, post-surgery, an infection won't become obvious until 2 to 7 days, and the patient is often home at this point. The infections can lead to osteomyelitis and sepsis. So you want to make sure you're teaching your patient the cardinal signs of infection and when to call a doctor if there's any complications of infection occurring. So dehiscence is another complication. It's the partial or total separation of layers. It can be a result of excessive stress on an unhealed wound from coughing or lifting. It can be caused by poor nutrition or by infection. The patient will feel a pop or a tear, and if they complain of this, check the incision, have them lay down if it is starting to separate, keep them on bed rest at an angle of less than 20 degrees, keep the knees flexed. A binder can be used to help support a dehisced wound, and you're going to want to call a doctor, and they possibly will resuture or leave it open depending on how it presents. And then a complication of dehiscence is evisceration. In this case, the wound is completely separated and protrusion of viscera through the incisional area occurs. You want to cover the wound with sterile towels and sterile normal saline and call the doctor. Put the patient on bed rest, keep the knees bent, and set up a surgical consult immediately. So with evisceration, you would not want to use a binder because this can cut back on the circulation to the area and cause ischemia and death to intestines or whatever the viscera is protruding. Another complication is a fistula, which is an abnormal passage from an internal organ or vessel to the outside of the body or from one internal organ to another. It is often the result of an infection which has formed an abscess that has not been able to drain. The accumulated fluid causes pressure on the surrounding tissues, and then this causes breakdown between the different organs. In order to prevent the buildup of fluid and the formation of fistulas, you often see wound drainage systems placed in surgical incisions. The Hemovac is one type. It looks like an accordion. What you do is you compress the container and it draws through negative pressure the fluid out of the body into this container. The Jackson Pratt, they look like little grenades. Same principle. You compress the drainage system and it draws the fluid out into the collection device. As you see, this drainage here, it's a red, it's called a serosanguinous drainage, and this is what you want to see. It looks like a healthy drainage, and it's good that it's getting removed so it doesn't develop any infections. The Penrose is another type of a drainage system, and the Penrose has an open end. It does not have a collecting device. It goes right into the gauze or the wound covering, and you want to make sure that you're changing this frequently so that moisture doesn't irritate the skin around the incision. And what happens is, as the drainage becomes less, the doctor will ask the nurse to pull a little bit of this out every couple days and cut it off, and eventually it just comes out. It's not sutured in place, whereas the Hemovac and Jackson Pratt are sutured in place, and that's removed by the doctor. Another type of wound drainage system is the T-tube, and that's for bile drainage, and it's connected to a drainage bag as well.